On December 1st, 2011, Rush Park Auditorium hosted the last in a series of county-wide town halls on the subject of Alzheimer's disease, sponsored by State Senator Tom Harmon and State Assemblyman Jim Silva. Present were representatives of both state officials and an audience of over 300, eager to hear what four noted Alzheimer's researchers from the University of California Irvine Institute for Memory Impairment and Neurological Disorders had to say about the current status of research in the field, the facts and the myths surrounding this emerging epidemic.
Good afternoon. If everybody would please take a seat, find themselves a place where they are comfortable.
Moderator for this discussion, which included Q&A from the audience, is Elizabeth Toomey.
I'm Liz Toomey. I'm the Assistant Vice Chancellor of Community and Government Relations at the University of California, Irvine. And we are just delighted. When I say we, myself and the team of folks from UCI Mind are absolutely delighted to have this opportunity to come and share with you our program there at UC Irvine, UCI Mind.
Before introducing the panel, Ms. Toomey brought forward two representatives of Alzheimer's support organizations in Orange County, providing critical services to Alzheimer's sufferers and their families.
At this point, I would like to introduce Patty Barton Mouton and have her have a couple of remarks about the outreach activity and advocacy for the Alzheimer's Association for Orange County.
Good afternoon. Thank you, Liz. I really appreciate that. It's really a pleasure to be invited to join you all this afternoon. The Alzheimer's Association is really a very proud and robust partner with UC Irvine Mind Institute and the Alzheimer's Family Services Center. We are blessed in Orange County to have a world-renowned diagnostic center and some of the world's top researchers into the problems of Alzheimer's disease and related forms of dementia at UCI Mind. So I'm not going to take the time of the brilliant academicians and clinicians for your panel. It's my pleasure to be able to remind many of you that the Alzheimer's Association, part of the national network of Alzheimer's Association chapters across the country, here in Orange County offers a variety of comprehensive services of support and education and information and referral. We have a 24-hour helpline that's available to anyone, a healthcare professional, a family caregiver, an individual with the disease. We'll answer questions, we'll provide referral to community resources. Sometimes we'll just talk you through a family issue. But we're there to support you 24 hours, 7 days a week for free. We also offer care consultation with licensed clinical medical social workers, for counseling sessions, for developing of care plans, for helping you get to the healthcare professionals that can provide you with an appropriate diagnostic program and treatment plan. Part of my job is legislative advocacy. So we call on our elected officials here in Orange County at the federal, state, and local level to help implore them to advocate for the issues that directly impact the people that we serve. Families and individuals living and coping with Alzheimer's disease and related dementias. So this year we've had kind of some excitement with a pretty good, not a great outcome, but a pretty good outcome that at least protects some of the services involved in adult day health care. And I would like to give a special shout out to Assemblyman Jim Silva for his unwavering support of adult day health care. We really appreciate that. Not all of your fiscal conservatives in California were quite as robustly supportive of this program. So, and people are having wry laughs over there. It was kind of an ugly fight. To use Assemblyman Silva's term, it was ugly in Sacramento. But through a series of events and a most recent settlement from a federal judge, the program will survive in a new iteration, but it will be available as the continuum of care. Other things that the Alzheimer's Association supports are the Medical Alert Safe Return Program, because people with many forms of dementia have a compulsion to wander from their caregiving situations, and it's very dangerous. So we support that program that helps to identify these at-risk individuals and then get them safely reunited with their families or care situations, and we help to outreach and educate the law enforcement and first responder population so that they know how to recognize someone with a dementia as opposed to someone who might be intoxicated or just being unruly. So that's a big part of our mission as well. A large part of my work this past year has been in outreach to our medical community, to our primary care physicians, and to physicians in the community that perhaps do not have Alzheimer's or dementia as an area of particular expertise. So we're calling on your internal medicine physician and providing them with information about the latest updated diagnostic criteria, the first time in 27 years that the diagnostic process for Alzheimer's disease has been updated by the National Institutes of Health. So we're making sure they know about it. We're making sure they know how to make an accurate diagnosis and when to refer to the experts like what we have at the UCI Mind Institute. So we appreciate you being here. We know that this is truly a top-of-mind issue. Alzheimer's disease is the defining epidemic of this century. And as we baby boomers continue to age, Lord willing and the creek don't rise, we all will get to be a ripe old age, it will become a disease that impacts everyone in some way. The costs are astronomical, both financially, emotionally, physically. We want to be there to support caregivers, to get them into support groups and into programs of education that help them cope. And we want to do our best to raise funds to continue funding the research, like what happens at UCI Mind Institute, and to get to an end, to get to a world without Alzheimer's. Thank you very much.
I listen to someone like Patty and I think of what she brings to all of us, really, and what her organization brings to all of us. And so I call out Patty as one of those special individuals that I hope we are training someone at UC Irvine, and I'm sure we are training someone at UC Irvine who will follow in her footsteps, because that's what community is all about. So thank you, Patty. Cordula has been recognized. I was going to let, anyway, I don't know what I was going to do. But anyway, Cordula has some things to say to us now before we get going. But before you come up, I do want to call out the two gentlemen that are on either side of the audience with the cameras in front of them. They are from the Los Alamitos Community Television Station, LATV3, and they are filming today's program. And it will be broadcast next week for those individuals who were not able to attend, or for those that are here today that would like to see what is talked about and shared today a second time. So we certainly appreciate those individuals from the community television station. So thank you. Cordula.
Thank you so much. I will be brief and just let you know that Alzheimer's Family Services Center is so proud to be here with UCI Mind and the Alzheimer's Association of Orange County to increase your knowledge about Alzheimer's disease, other forms of dementia. 70% of people with Alzheimer's disease live at home, and as many of you know, caregivers are at great risk due to the stress that this causes, both mental and physical health problems and even premature death. At Alzheimer's Family Services Center, our goals are to improve quality of life for people with dementia and to help provide solutions for care, to help lessen the burden of care. And there are three primary ways we do this. We do this through adult day healthcare services, which Patty just mentioned, that provide recreational activities, health services, care during the day. We do this through caregiver support, such as support groups, counseling, and we do this through education by being involved in activities like this. I also want to express my deep appreciation to both the offices of Senator Harman and Assemblymember Jim Silva. I will have to tell you, Alzheimer's Family Services Center wouldn't be right down the street in Huntington Beach if it weren't for Senator Harman, who happened to be on the Huntington Beach City Council when the building got approved. So both Senator Harman and Assemblymember Silva have a long-term commitment to advancing the care of people with Alzheimer's disease, to supporting their families, and this event reflects their ongoing commitment to that. And as you already heard, I am so proud that as of January 3rd, I will be with the UCI Mind, Institute for Memory Impairments and Neurological Disorders, as the Director of Education, very deeply involved in events like this as well as many other activities. So I am going to pass it back to you.
Thank you, Cordula, and my congratulations to the recognition that you received today from Senator Harman. That really is wonderful, and welcome to the family, UCI family. All right, this is what you came for, and that is to hear from our very fine physicians there at UCI, researchers at UCI. And so at this time, I would like to introduce Dr. Frank LaFurla, who is the director of UCI Mind, and is just recently, and we are delighted to have him as the chair of the, just a minute, I wrote it down because I did not want to, the chair of neurobiology and behavior at UC Irvine. He is just such a wonderful part of our academic family, and so it's with my pleasure to have Dr. Frank LaFurla come forward and introduce his team. As he is coming forward, I just want to call out a little housekeeping, a couple of little housekeeping things. You have a postcard with your information, and we invite you to fill this information out and leave it with us so that we can continue to be in communication with you. We are there, as I said. One of our legs on that stool is public service and community service. And so we want to stay in touch with you and be there for your needs. So please, take the time to fill this out and leave it with us. The other thing is that the cordless mic had a bit of a problem. So what they're going to do after the presentation and we go into the Q&A is that they will move this microphone down to the front, and you'll be able to come forward and ask your questions at that time. So with that, Dr. LaFurla.
Thank you, Liz, and thanks to everyone for putting together this very special event. And UCI Mind is very, very excited to participate in this. So let me, without any further ado, introduce our panelists, because I have the pleasure of working with an outstanding and great team. And so let me first introduce Dr. Malcolm Dick. He is our licensed clinical psychologist. He has been at UC Irvine since 1985. Come up, Malcolm, please. And just to show you the kind of impact that he has had, since that time, we estimated about 2 years ago that he has evaluated over 7,000 residents of Orange County. So talk about an impact and a contribution to help fighting the war against Alzheimer's disease. Malcolm is certainly on the front line. Now, our newest member of our team is Dr. Amy Pierce. She is a well-trained and an outstanding neurologist. She received her MD from Columbia University and then went on to do her residency at UCLA, and then did a dementia specialty fellowship training at the University of California at San Diego, and she just joined us as of July of 2011. And not only that, she didn't waste any time. She immediately established a long-term care clinic for individuals who are suffering from dementia. So let's also welcome Amy to the panel. And last but not least is my longtime colleague, Dr. Kim Green, who has been with UCI since 2003. He actually received his PhD from Leeds University in England in 2002, and his specialty is on Alzheimer's therapeutic and also on understanding disease mechanisms. So with that, let's welcome Dr. Green to the panel. So I'm going to have to sit over there so we can move this podium down. And, let's see if this is on. Can you hear me? Okay, so let me just give you a little bit of background as to how this Ask the Doc program started. And at UCI Mind, we would routinely give a lot of lectures to the lay community. And when we would do this, we found that so many members of the audience had questions that they wanted to have addressed that there simply was not enough time to address them in a 10-minute time slot. And so we started off small with an Ask the Doc in someone's house, and we had about 30 people attend it, and then it continued to grow. We did one in South Orange County for a bridge club that had about 400 attendees. It was featured in the Wall Street Journal and also in the Orange County Register, and it turned out to be immensely popular that we're being asked to try to conduct these Ask the Docs wherever we go. And what it does is enfranchise you and give you the opportunity to ask questions that you have about Alzheimer's disease. The only thing that we ask is that you keep your questions as brief as possible, and you try not to make it too personal and make it more generic so it could benefit as many people in the audience. Now, let me just give you a little bit of background before we open this up, and I don't mean to scare anyone, but many of you probably know that age is the most significant risk factor for Alzheimer's disease, but you might not know how really scary the statistics are. So it turns out that 5% of the population over the age of 65 is afflicted with Alzheimer's disease. And that number doubles every 5 years thereafter. So let's do the math together. We're talking about 1 out of every 20 people over the age of 65, 1 out of every 10 people over the age of 70, 1 out of every 5 people over the age of 75, and 1 out of every 2 to 3 people over the age of 80 to 85. So essentially half of the population over 85 is affected by Alzheimer's disease. So since Orange County ranks 5th in the nation in terms of having the largest baby boomer population, this is an epidemic that's occurring in our own backyard. And you heard during the introduction that right now we estimate that there are at least 75,000 people in Orange County that are suffering from this disease. To put that in perspective, there are a total of about 60,000 residents of the state of Colorado that have Alzheimer's disease. So way more people just in the county of Orange that are suffering from this. So this is a looming problem. I can almost guarantee that if you currently don't know someone with Alzheimer's disease, you will, unless we can alter the course of the disease. So with that, I'd like to open up the field to the audience, and please don't be shy. This is only works if you're able to come forward and ask your questions. But while things are warming up, and I realize people sometimes get shy, I usually like to start off and ask the first question, and I'll ask Dr. Amy Pierce a very important question related to medications and Alzheimer's disease. And from your experience, what type of medications should someone avoid if they are worried about having memory-related problems or if they already have a diagnosis of Alzheimer's?
So that's a great question because several medications can impact a person's cognition as they get older and lead to confusion, lead to sedation, and really worsen how a patient is able to perform and think. And it's definitely the case that a lot of sleeping pills can impact cognition in older patients. In particular, even over-the-counter sleeping pills, like Tylenol PM, that usually contains antihistamine, like Benadryl, and that can affect cognition as well. Some of the other prescription medications, like other sedatives or anti-anxiety medications, can impact cognition. And then the other main ones to watch out for are medications that are used to treat urinary symptoms. Sometimes, surprisingly enough, they can have a distant effect on cognition. None of these effects are permanent. They're the type of effects where it's always wise to discuss with your own primary care doctor or your pharmacist about your medication list and review, make sure everything's there for a good reason. But it's quite the case that we see what we call polypharmacy, where patients on many medications which are interacting poorly together but can also have cognitive effects as well.
Good, thank you. So how many people go to a mall and forget where they park their car? Right? Or you forget where you leave your keys, right? That doesn't necessarily mean that you have Alzheimer's disease. So let's start with Dr. Dick and ask him this question. When do you have to start worried that your temporary memory lapses might be a little bit more serious?
Well, I think that's a good question that's often asked. When should I be worried that I'm coming down with a memory problem? I think as we all age, me included, we start to notice changes in our cognitive abilities. So, for example, some of the common changes that are seen in healthy older adults are that it takes us longer to learn new information. So, for example, we might have to read an article a couple of times before it really starts to sink in. Also, in addition to being slower at learning, we also are more susceptible to distraction. So, for example, as I've gotten older, I've noticed I can't have the TV on while I'm trying to read. I have to do one thing at a time. So we're increasingly susceptible to distraction. So we have a slower learning rate, we have more susceptibility to distraction. Another common thing that is reported in older adults who are healthy is word finding difficulty, where they know what they want to say, but occasionally they'll slip up on the right word to come out. And that's not unusual. Probably 60% or more of healthy older adults will report occasional word-finding difficulties. So there are changes that go on as we get older with our memory, with our language, with our attention. We're slower at processing information, for example. So those are not unusual changes as we get older, and particularly the older you get, sometimes the more difficulty you'll have. The difference between normal aging loss and that of, say, a disorder called mild cognitive impairment, which we'll probably talk about later, as well as Alzheimer's, is that the memory problems become much more noticeable, not just to the individual, but to family members, and they start to impact their day-to-day life. So when you start having a memory problem that is affecting your ability to function, then that is really not part of normal aging. Normal aging shouldn't have that. Also, with the memory loss that you see in normal aging, they often have a difficulty in recalling information. So, for example, they may not remember the name of the actor that they're watching on the TV. But with Alzheimer's disease, they not only have difficulty remembering the name, but also if you give them a hint or a reminder, you give them, say, a couple of names and they have to choose which one is the individual. An Alzheimer's patient often will not be able to benefit from these cues or reminders, while a normal, healthy adult can. So I think normal aging, we do see some loss of memory abilities, but in normal aging, if you give a person a reminder or a hint or they get a cue, it'll come back to them. Alzheimer's disease, you won't see that. So that's one of the ways that you can help tell whether or not this is normal aging loss or a more serious problem. But in general, if it starts to be affecting your day-to-day life, then that is not normal, and I would recommend getting some kind of an evaluation or talking with your doctor.
Okay, thank you. Okay, let's make this as interactive as possible. Does anybody have a question? If you mind, please go to the podium.
Sure. I have, anybody? Oh, okay. In the December 11th newsletter from the Department of... In the December 11th newsletter from the UCLA Division of Geriatrics, Healthy Years, there's a statement in here: iron accumulates in our bodies as we age. In the brain, it contributes to the development of abnormal deposits of proteins associated with several prevalent neurodegenerative diseases such as Alzheimer's, Parkinson's, and dementia with Lewy bodies. Does this mean that if one has one of these diseases, they should limit or severely reduce their iron, that they should possibly give blood, whatever it takes, because there's a very difficult way to get iron out of the bloodstream? But how does one cope with this? Is this a meaningful thing? I mean, it's interesting data, but...
Right. Great question. First thing, you should not be reading things from UCLA. Sorry. Amy, you want to take that?
Well, I did neurology residency up at UCLA, so I would disagree. But no, it's true. I'm here at UCI now, and UCI is better. But no, I am familiar with the research going on up at UCLA about iron accumulation and iron deposits in older persons' brains, and in particular with these neurodegenerative diseases. But this is still at a very, very early stage of research, and it has not been shown that the iron deposits are causing these diseases or making them worse. They're associated. And certainly, even if you went up to UCLA, they wouldn't give you any advice for donating blood or doing chelation or anything like that. This is basic science, which is often very important, and we love to inform the population about our basic science, but right now there's no medical recommendation about anything to do with iron, or even limiting your iron. Now, iron is, generally people don't take it as part of their regular vitamins unless it's prescribed for iron deficiency. If that's the case, and that's prescribed for iron deficiency, then that should be continued. But otherwise, it's not for prime time yet.
I think that, if I could just add, I think there's very little evidence that your dietary intake contributes to accumulation within the brain. So I want to second what Dr. Pierce said about not limiting your dietary iron. Now, having said that, there are some drugs that are in different phase 2 clinical trial experimenting with the possibility of chelating the iron, but the results of that are not yet clear. And so it's still at the very early stages.
Can I have a
Sure.
follow-up?
Yeah, please.
This, of course, first of all, I'll preface this, I'm an engineer. I have nothing to do with any of so these may not make any sense. But we all know what osmosis is. We all know how to get cholesterol out of the blood and those kinds of things. Is there anything, if this is indeed what it says, an accumulation of abnormal protein in the brain, would any of these other mechanisms possibly want one to limit the amount of protein, or a particular type of protein, to go to something like a vegetarian or a diet, in order to try to get one of these mechanisms to get the protein out of the...
Kim, you want to try to answer that?
I can try. Essentially, the brain is sort of separated from the rest of the body by something known as the blood-brain barrier. So things have a hard time getting from your blood into the brain itself. So it's not as simple as some of these other, cholesterol-lowering drugs and things like that. Now, with regards to iron deposits in the brain, we know that these plaque proteins that accumulate in the brain are very sticky, and they can stick with various heavy metal ions, including iron and copper and zinc. But we really do not know what sort of role this plays in the disease progression, whether or not it's protective, whether or not it accelerates disease, or anything else. So, as Amy said, there are no recommendations at this point to try and touch these systems at all. There is research that is ongoing that looks at clinical trials and will, over the next probably 3 to 4 years, come out with a recommendation. But until then, it's best not to touch these things.
Okay, thank you.
Thank you.
Is this a disease that's becoming more and more prevalent, or is we're just becoming more aware of it? And are they nailing down any externalities, things that might cause you to get this disease? And second part of that question, is there anything that can help you to prevent getting the disease?
Great questions. Amy, you want to take a stab at that?
So I don't think there's any evidence that the disease is becoming more common in our modern age. I think it mostly has to do with our aging population. And so as we've been better able to treat heart disease and cancer and people are living longer, then you're quite right, it is becoming more recognized because the population is aging. And also for demographic factors, our population is aging. By the same token, also 20, 30 years ago, it was, senility was a concept that it was considered in some ways normal for people as they get older to lose some of their cognitive abilities and their memory. And now it's quite clear that senility is not normal, and it actually does in many cases, probably about 70% of the time, represent Alzheimer's disease dementia. And we do realize that some people can age very successfully and have healthy brain aging and not succumb to that, and others do succumb to it. And then as far as the best lifestyle factors, it turns out that a lot of the same vascular risk factors that put you at risk for heart disease or stroke can also raise your risk for Alzheimer's disease. So things like high blood pressure, high cholesterol, diabetes, those sorts of things. And so all of those things are, monitored in your yearly medical exam and kept track of, and should be controlled to the best of the ability. And then the others include exercise and both physical exercise and intellectual exercise, and keeping your mind active and your body active has been shown to reduce risk of Alzheimer's.
Let me just highlight something that Dr. Pierce just said. How many people in here remember when you were younger and you saw an older person acting out of character, you would refer to that person as senile, right? And I bet you probably no one refers to anybody that way anymore, because we now recognize that most senility is due to a disease process like Alzheimer's disease. So let's take the next question.
My name is Maurice Roger. I'm the American chairman for the BFW and the American Legion. I would like to point out to you that the American flag is way back there. The American flag should be up front to honor the flag. So not in the background, but in the front. Thank you.
Very well said. Can we move it? Okay, yes, if you don't mind, if we can move it, that'd be great. Have another question here.
I'm confused. Is there a distinction between Alzheimer's and other forms of dementia? If so, how important is it to make that distinction?
Yes.
And also, is it an important factor to monitor the progress of the disease? And if so, how often,
Okay,
et cetera?
great questions. How many people in here understand what the difference is between dementia and Alzheimer's disease? So few people do. A lot of people are often quite confused about that. Malcolm, why don't you answer that question? Tell us what dementia is first.
Well, I think the best way to conceptualize dementia, think of the word dementia as a global term, like the term cancer. There's many different types of cancer, and there's many different types of dementia. But a dementia is it's not essentially a disease. A dementia is called a syndrome, and it's made up of three key features. The first, to have a dementia, you have to have a significant memory loss. Secondly, there has to be one or more other what we call cognitive changes, and by that I'm referring to, in addition to the individual maybe being very forgetful, they also have to have other mental abilities affected, like their language or their reasoning abilities, or they're starting to get lost, so there's visual spatial deficits. So you have these two cognitive or brain-related changes, memory plus one or more other cognitive deficits. And the third feature of a dementia is that these have now got to impact or impair the person's ability to function in their day-to-day life chores. So they're because of the memory changes, they're no longer able to pay their bills, or they can't balance a checkbook, or they're getting lost going to the store. So for a dementia, you have to have those three features, and you can have anywhere from a very mild dementia to a very severe or profound dementia where the person may be bedridden and unable to communicate. And within that sort of circle that we call dementia, Alzheimer's disease is probably accounting for perhaps up to 70% of those dementia cases, with vascular disease maybe the second most common cause, accounting for perhaps 20%. And then there's something called dementia with Lewy bodies that accounts for maybe 15%. And then the remaining 5 to 10% is a lot of other potential diseases that can affect older adults. So if the doctor says you have a dementia, that's just like saying, well, you have cancer. You want to know, well, what kind of dementia and what can I do about it? Because the treatment for different types of dementia will vary.
So you would say that it is important to determine what type of dementia you have?
Yes, yes. Because as Dr. Pierce could easily tell you, you treat a vascular dementia somewhat differently than you would if you thought this was Alzheimer's disease.
So we need to lean on our doctor.
I think if you get a diagnosis of dementia, your doctor has not done his job. It would be like going to your physician and he gave you a diagnosis of cancer. If you had breast cancer, you would not want a drug that was used to treat prostate cancer or vice versa. And the same thing should apply to all of dementias.
Okay, thank you very much.
Is Alzheimer's disease a genetic disease, number one? And if it is, can you be tested? Are there any tests you could take for a gene that might mark for it?
Kim, you want to answer that?
Sure. Okay. So there are two different forms of Alzheimer's disease. One is known as familial Alzheimer's disease, which is a genetic disorder. The other form is known as sporadic. Now, this familial form only affects a very, very tiny proportion of patients, around 2%. So it's very, very rare. So chances are that people in this room do not have this. It's an early onset form of disease, and it occurs much younger ages and is far more aggressive. And this is inherited from your parents in a dominant fashion. The other form of Alzheimer's is sporadic, and this is what the vast majority of people will go on to develop. This is 98% of Alzheimer's disease cases. And we're beginning to understand more and more about what causes these 98% of patients to go on to develop Alzheimer's disease. And it's a combination of two things. It's a combination of your genetics and also your environmental factors. And it's not inherited in a strict sense from your parents. What it is a risk for developing the disease. So your genetics can influence whether or not you will get the disease, but they cannot guarantee that you will get it. So there are certain genes that we can test for that will that display a higher risk of developing the disease as you get older. And one of these is known as ApoE, apolipoprotein E. And there's a variant of this called ApoE4, which actually 50% of Alzheimer's disease patients have. But it's not recommended that anyone get tested for this at the moment, but it is something that people can look at. So genetics do play a role in the disease. It's not clear how big a risk this is, but at the moment there's not much we can do about it. So it's best just to keep a healthy lifestyle and hope for the best.
Amy, let's follow up on the previous question, embedded in that was the implication of why an early diagnosis is valuable, and if you provide an early diagnosis, what kind of treatment options are available for the patient?
So I think that an early diagnosis is valuable for a variety of different reasons, but there are 4 different FDA-approved medications for Alzheimer's disease. 3 of them are in the same family, and so they aren't used together. You only use one, and then the other is in a separate family, and is used a bit later in the course of disease. But in the case of mild Alzheimer's disease, these medications can be beneficial. They are not a cure for the disease in any sense. We do not have one, but they can give patients a small boost in their cognition and performance, and can also slow down the deterioration to some degree. And so it is, if a person is diagnosed with Alzheimer's disease, the earlier the better to try one of these medications and try to get a benefit. It also is very important to be diagnosed early if the patient is starting to have any problems at work or any problems in their home life. It's important to understand why that's happening. And not to blame the patient, and recognize that this is a disease, and patient may need to make arrangements at their work. They may need to make arrangements as far as their advanced directives and financial goals and all of that. And it's important to do that while the person has the ability to do so and to make their wishes known.
But you would argue, too, that no one would ever question getting an early diagnosis of cancer, right? But for some reason, there seems to be this reluctance of trying to get an early diagnosis of dementia.
You're quite right. I guess there is some of a fatalistic type attitude among some patients, and in fact among some doctors as well. And I think that we need to ward against that, because it is, incredibly important for the two reasons I mentioned, to try early medication to make the wishes known, but also to begin the lifestyle changes which can slow progression, such as exercise, intellectual, social, and physical exercise. And then finally, and probably even most importantly, once you have a diagnosis, then you can begin to potentially participate in research. And there is so much research going on, clinical trials, observational trials, imaging, all sorts of things. And you cannot participate in those unless you have a diagnosis, and we can't advance the field unless we have participants. Those are the most important people in our research endeavors.
Well, very well said. So just an administrative note, there's a clipboard that's making its way around both sides of the audience. In case anyone's shy and doesn't want to get up and ask a question, you could just write your question down on there, and then someone will read it. But obviously this gentleman's not shy, so please go ahead and ask your question.
All right. I wonder, is there any way to determine in advance a person who has the passive type of dementia or one who gets very aggressive with it? Because I know of a case where this happened, and had been passive all his life, not a problem. Mm-hmm. And suddenly, just in a matter of a few short months,
right,
extremely aggressive, and it ended up getting him in jail, and he died there just like that with substandard medical care.
Malcolm, you want to answer that?
So I think you're asking, can we predict, what are going to be the behavioral symptoms we see in any given Alzheimer's patient or dementia patient? Well, in certain types of dementia, for example, in frontal temporal dementia, which tends to affect people at a younger age, you can see some different kinds of behavioral problems occur than you could, say, in Alzheimer's disease. So a frontal temporal patient might be much more disinhibited. They might be more aggressive with others. An Alzheimer's patient might retain their social skills until very late of the disease, and they may never show a marked personality change. So I don't think you can say at this stage of dementia you're going to be seeing these kinds of behavioral problems, or in this individual you'll be seeing this at some point. Individuals can vary greatly in terms of the symptoms. Some will remain calm and easygoing all the way through their disease, and others might have been a calm individual, and then as their brain changes, they become more aggressive. A lot of it also may be related to how that individual is treated. If there's an important role that the caregiver has in terms of understanding how to deal with an individual who is forgetful, and the caregiver, by not intentionally, may aggravate that individual, and that's where support groups, education such as offered by the Alzheimer's Association can be very helpful in teaching caregivers how to interact with the patient to reduce the likelihood of certain types of unfortunate behavioral problems occurring.
You have a question? Okay.
Perhaps I'm very fortunate, but I don't think I know anybody who has Alzheimer's disease. Maybe that's because they're taken out of society, they're put away in homes or something. And so I'd like you to answer, what are the terminal cases? What happens when people, quote, die of Alzheimer's disease? What's involved in that? And second is, what's the temporal progression from the time that the person starts showing? You said that 75, 50% of people or so are.
No, that's at 85, so it's 70.
Okay. Well, at any rate, what's the prognosis? How long is this a 3-year, 5-year, 10-year? And in particular, I'd like to know what are the final stages of it, because having not seen it, that's perhaps what worries me most about how you would take care of people, or how you would want to be taken care of yourself, whether or not you would want to have palliative care if you get to a certain point. Could you describe this most unhappy?
Right, those are all fantastic questions. And I'll let Dr. Pierce answer that question. But let me just put it in the most simplistic terms. How many people in here use a computer on a regular basis? Just about everyone today. And you know how much damage gets wreaked in your life when your computer hard drive crashes. Imagine what happens when your body's hard drive crashes, which is your brain. And that's what you're facing. So, Amy, would you answer that question?
Sure. So, as you know, Alzheimer's disease is a slowly progressive disease. And so from the time of diagnosis up till the time of death is often 8 to 10 years or longer. However, keep in mind the patient often has symptoms for years and years before diagnosis is even made, and 4 or 5, even longer years before diagnosis is made. So the course of disease is actually more like 15 to 20 years. As the disease progresses, it's initially forgetfulness, then progresses to involve other areas of cognition, and then can progress to affect language. The patient probably will start to speak much less and less, will have difficulty communicating their needs and what's troubling them, what's causing them pain. Often at end and later stages, it begins to affect the way that they walk, and they will become wheelchair bound or eventually bed bound, and they'll have difficulty feeding themselves. And in general, Alzheimer's disease, the plaques and tangles and atrophy in the brain, that in itself is not exactly what causes someone to succumb. Usually it's the fact that the patient is bedbound and then can develop bed sores, or the fact that their ability to control their swallowing and breathing is affected, because that's controlled by the brain, and so they could develop a pneumonia or another type of infection, and that's usually what happens towards the end.
So with this disease, what's interesting about it, it's perhaps the only human disease where the initial diagnosis is usually made as a joke by a family member. Think about that. The patient does something that's out of character. They may go on and leave the stove burning. They may go outside naked to pick up the newspaper, something that's completely out of character, and one of their family members looks at them and says, "What do you have, Alzheimer's?" No one ever looks at you and says, "What do you have, cancer?" But this is the only disease that is really like that. So we're getting all these questions now from our panel, from the audience members. Do you have a question? Yeah.
As far as the caregiver's role, the law is not too friendly in the form of caregiving. To that caregiver side. Case in point, a person who's affected is going to either do damage to themselves or to others. And if that caregiver attempts to, let's say, restrain them, then the law is not favorable from that standpoint. The person now is actually bedridden, but could benefit tremendously from physical therapy and get themselves back walking. However, that caregiver, that's their only defense, is to have that person down. It's a ugly situation, but I would like someone to at least talk about that as far as what the caregiver needs to do in order to try to help defend this. Also, the second question, the dementia, the cognitive challenges, they get two highs and they get two lows, whether it be, bipolar or whatever. And there's a part of that high that, as a caregiver, you like. You like them laughing. You like them doing those things. But then when they go to that other extreme of frowning and finging, and you try to get them to change their thoughts. As a caregiver, how much damage are you doing to them by allowing the laughter but not addressing, and trying to change the thought of the negative frowning?
So that's an outstanding question. I'm going to ask Cordula to actually help address that. Cordula, I think that mic is live if you want to just use that one. This is certainly your area of expertise.
First of all,
is it active? No, okay. Okay.
First of all, there is never a reason to restrain someone with Alzheimer's disease. There are always different ways. Now, sometimes it takes some work and problem solving to find those ways, but we really want to refrain from dehumanizing the person or using restraints, and actually restraints can lead to more injury and even death than not restraining a person and using some different strategies. Now, again, this gets back to Frank's early comment about general versus specific questions. To help you solve that problem, you need to really sit down with someone who can look at the specific situation and problem solve and brainstorm with you different ways of dealing with your loved one with dementia. So the Alzheimer's Association care consultations, Alzheimer's Family Services Center, we all have social workers and other professionals who can help you deal with these kinds of issues, and I'm happy to talk with you afterwards. In addition, in regards to the expression of emotions in people with Alzheimer's disease, they do express a wide range of emotions and experience. Even when they've lost some of their cognition, they still have experiences and awarenesses of the changes that are going on. And so you may see people becoming sad. And yes, trying to use strategies to help comfort them are very important. Sometimes it's as simple as music, or giving them a teddy bear, or giving them a massage, or doing something that's going to comfort them. So it's more that you as the caregiver need the tools, and that's why agencies like Alzheimer's Family Services Center and the Alzheimer's Association are here to help give you those tools so you don't end up unnecessarily restraining someone.
So we have a question from the audience that's written down here, very interesting, and I think, Kim, you could probably answer this, and it relates to fish oil and whether or not it's beneficial for the brain and what other supplements might be helpful. And you've done some cutting-edge research on this.
Sure. So actually a very large clinical trial was done with DHA, which is the beneficial oil that's found in fish oil. In mild to moderate Alzheimer's disease, but also just in normal age-related memory impairments. And unfortunately, it didn't show any effects in the Alzheimer's disease population. Unfortunately, it wasn't effective. But what they did find was that it did have some effect just in normal age-related cognitive impairments. So what that says is that it's not effective once you start to get Alzheimer's disease, but it can be effective just in the aging process itself. So DHA looks good, at least maybe in the very early stage of the disease, or just for an aged person to take. No other supplements are actually recommended. There's nothing out there that has been shown to protect against Alzheimer's disease in any way, shape, or form at the moment. We have a lot of preclinical research that highlights certain things, curcumin, ginseng, all these sorts of things, and they show some benefits, at least in the science lab, but so far none of them have proven to hold true when taken into patients. So at the moment it's sort of cautionary that anything you read on the internet that says it might help Alzheimer's does not necessarily mean that it will help in patients. It means that this is research that has gone on, that in the science lab shows some benefit, but this may not translate well through to people. So to summarize, the fish oil, the DHA supplements that fish oil consists of, show some benefit in age-related cognitive impairments, just normal age-related cognitive impairments, but don't seem to show any benefit in Alzheimer's disease itself. And no other supplements are actually recommended or have been shown to have any beneficial effects, unfortunately.
Okay, we have a question here.
Dr. Pierce, were you you said that there were 3 medications in one category and one other. Were you going to name those, or did we?
Sure.
I'm not sure if we took you off the track. And secondly, my mom seems to be very stable as far as her information processing, but memory is still declining. So should we look for a different medication, or is it really just our imagination, or like a lot of benefit with galantamine and just layering of ideas, but steady decline of memory still.
So galantamine is one of the cholinesterase inhibitors, and these are medications which stop the breakdown of acetylcholine, which is a neurotransmitter, which is used for the neurons in the brain to communicate. So galantamine is one. Donepezil is another, that's Aricept. That's probably the most commonly used one, or most commonly advertised. And the last one is rivastigmine, and that can also be given as a patch form. So these medications are used in the treatment of mild Alzheimer's disease and throughout the course of the disease, and you only take one, you don't take all 3. They work very similarly, and so it's unlikely that someone switching from one to another would give someone any more notable benefit. The main reason someone might switch is that sometimes the side effect profile is a little bit different, and someone might have more nausea or diarrhea with one of the pill forms and can't tolerate it, and in that case it might be wise to switch them over perhaps to the patch. Sometimes people do better with that. The 4th medication is called memantine or Namenda. That medication works completely differently, and it works to block a receptor for a different type of neurotransmitter called glutamate. Blocking this reduces excitotoxicity, or death of neurons from too much excessive activity. And this medication has not been shown to be helpful in the mild stages, but when a person is moderate to severe, it's recommended that that medication be added onto their regimen, and mainly that medication is more useful for controlling behaviors and also maintaining a person's functionality. It doesn't have so much memory effects, the memantine or Namenda. And there's many different medications in clinical trials right now. Those medications I mentioned don't get at the plaques and tangles of Alzheimer's disease, but several of our medications and trials are looking at trying to affect the actual pathology happening. And so again, consider clinical trials.
You mentioned specific supplements and the relative lack of effects or evidence. Even if the answer is just no, I wanted to ask about a specific one I read about years ago that had clinical promise, but are you aware of any evidence at all towards L-carnitine and lipoic acid as supplements?
Well, lipoic acid, it's a powerful antioxidant, and it's been, I think there have been clinical trials in Alzheimer's disease, and once again, no effect.
Right.
So with all these supplements, the reality is that it doesn't hurt you. So it's the sort of thing that many people feel they want to take just because it may offer them some protection. But the evidence in a clinical setting is no, it doesn't help.
All right. Thank you.
So here's a great question that someone wrote in, and we won't ask who, but they wrote, can a person with dementia still drive? Malcolm, do you want to answer that question?
Well, I'll say something, and then probably Amy can say something in addition. Can a person with a dementia still drive? Well, I think yes, they can. A lot depends on the severity of their dementia. In California and a number of other states, if a physician or a doctor diagnoses a dementia, they are mandated by state law to report that individual, and they would then be tested by the Department of Motor Vehicles to determine their safety on the road, and they would do the written and the manual test. And many patients in the mild stages, very mild or mild stages, can still drive. The DMV might place some restrictions on them. So they might say, well, you can't be driving, say, on the freeway, or you need to drive in your familiar environments, or maybe not drive under poor illumination, like at night or in a rainstorm. So they might place restrictions, but yes, we have quite a number of mildly demented patients who are still operating their motor vehicles and doing it quite safely. And in many cases, the patient, particularly if they have insight, will self-regulate. So they will say, well, I'm not going to drive on the freeway, or I'm only going to go to familiar locations. Now, when you get into the moderate and severe stages of a dementia, where you've got not just memory, but multiple deficits, attention, concentration, multitasking, in many cases, those individuals are not safe behind the wheel. And in many cases, they would not pass the written or the manual test by the DMV.
Amy, do you want to end? No? Okay. So here's another interesting question. Where can a person go for testing? Should they go to a neurologist, gerontologist, a regular internist, or their primary care physician? Do you want to answer that?
I think that often it is good to first bring it up with your primary care physician, of course. And depending on their level of familiarity or comfort or amount of time, because it does take a little bit of time to get a good evaluation, and unfortunately, many doctors are completely rushed, and I understand that and relate to that. So they may not be able to do a full evaluation, and so in general, it's. If there is a question, your doctor may refer you, or if you were unsatisfied with your evaluation, then it's good to go see a neurologist. And the area of neurology that specializes in this is dementia specialist or geriatric neurologist. And there are a few here in Orange County, but general neurologists in many cases can give you a good thorough evaluation, but they may send you on for an even more detailed one. There are also, you can be evaluated at UCI Mind as well. Those are the general places.
So Malcolm, talk to us about the evaluation process. If someone in here is concerned about their memory loss and they set up an appointment at UCI Mind, walk us through the procedures. What happens?
Well, at our clinic, it's typically 2 days where we'll have the individual come in. On one day, they will see a neurologist such as Dr. Pierce, and they'll get a comprehensive physical and neurological exam. And Dr. Pierce can tell you what she's looking for with the neurological exam. They'll also have come in, and that neurological exam might last an hour or so. The other day is where the individual and their family members come in and they do a neuropsychological evaluation. And in this case, we're evaluating the individual's memory, their language, their visual spatial skills. Essentially, we're trying to get an idea of all the different parts of the brain and how well they're working, and whether the pattern of deficits that we see on the cognitive tests, paper and pencil tests, are reflective of a pattern such as, say, early Alzheimer's disease, or is this Parkinson's disease, or stroke, or Lewy body dementia. So it'll be 1 day or half a day, really, for about 2 hours with a neuropsychologist, and during that time the family member is being interviewed by a nurse or another clinician to get an idea, how is this person doing at home? What are their medicines? What are their abilities? Are they driving? Are they able to help out at home? Can they manage their finances? What are the personality changes? And then the second day is usually the neurological physical exam. And the doctor may decide at that point that they need to get a brain scan, like an MRI scan or a CAT scan, or additional lab tests to rule out other possible causes, like a vitamin B12 deficiency or thyroid problems. So you can't diagnose this disease just by doing, say, an MRI scan or just by a short little mental status test. Until we have a better tool to identify it, it's a rather complex process that takes a while to do, but it's a very thorough examination that is provided, at least at our clinic.
Amy, what does the neurological exam consist of? What are you looking for when patients come to see you?
The neurologic exam is a physical exam in the office where a neurologist tests the functions of the cranial nerves, the muscles, the spinal cord, and the nerves. And the neurologic exam is a critical part of the evaluation for Alzheimer's disease or other causes of dementia. In particular, in Alzheimer's disease, often the neurologic exam is completely normal, and that's important to note. And that is why patients with Alzheimer's disease often, are very physically fit and can go out and walk 10 miles or walk 10 miles away from their home and that sort of thing, which can be a problem. But in other types of dementia, there often are deficits on the neurologic exam, changes in the reflexes, changes in the muscle tone, in Parkinson's disease dementia, that sort of thing. And the neurologic exam in that way helps us figure out what is the underlying cause.
So, Kim, in some senses, research is the only hope that we have for being able to cure Alzheimer's disease. But maybe you can give the audience a feel for why it takes so long.
Yeah, unfortunately, research takes a very, very long time. And, part of our job is to try and identify drug targets and then develop drugs that hit those targets. Then we have to evaluate them in animal models. And this itself can take several years to occur. Alzheimer's disease is a disease of aging. And when we work with animals and we test drugs that we think are going to work, we have to test them for maybe a year, maybe longer. Once we have selected drugs that we think are going to be beneficial, it can take a great deal of time to get those into people. And once you actually end up in people, the clinical trials in humans take years and years to actually get anywhere. And unfortunately, so far what we found is most of the things that work preclinically, work in our animal models of disease, have gone on to fail in people. And so we spend a lot of time, testing things which ultimately fail. But to actually get beyond those stages and get to something that we can get into the clinic takes many, many years of clinical testing. So once we identify promising compounds, promising therapeutic approaches, it can then take up to 10 years before those things are approved by the FDA and will actually start to be given to patients in the widespread audience.
Just to put this in perspective, the federal government spends about $486 million a year to support Alzheimer's research, but yet cancer research gets about $6 billion a year. By 2050, it's estimated that we are going to be spending roughly $1 trillion a year just to manage Alzheimer's patients. $1 trillion a year. And you can imagine that we will never be able to balance our budget with that kind of looming economic disaster on the horizons. Do you have a question?
About that testing that you do at UCI Mind, can you give us an idea of how much something like that costs and whether or not it's typically covered by insurance?
Sure. Malcolm, you can answer that.
Well, I can give you some brief answers. In the back of the room there is Peter, and if Peter will wave his hand.
Wait, Peter.
Peter is one of our patient care coordinators, and he interacts with the families and patients and can address all of your cost issues. At our clinic, I would say probably 80% of the cost is covered by Medicare, Medicaid. So most of it is covered, I think, by insurances. I think if you have specific questions, I would probably talk with Peter or Shirley in the back. If an individual has, say, come from their primary care doctor or a neurologist in the community and they've already done some of the testing, so for example, they may have a recent MRI scan or blood test, we don't repeat those. If they're recent and they're relevant, we don't repeat them, so that may lower the cost of the evaluation. But most of it, 80% or more, is generally covered through insurance.
Here's another question that someone wrote down, and it's actually, I'm actually surprised we haven't gotten to it, and maybe Amy, you could answer this, but someone wants to know, I'd like more information about mild cognitive impairment and whether or not Aricept is effective in MCI.
So mild cognitive impairment is a condition wherein a person has a mild memory deficit, which is detectable and noticeable to the patient. It can be measured on testing, so the patient is more than one standard deviation below the normal range for memory testing, but it is not yet causing any functional impairment. So they're still able to work, do their finances, manage their medications, that sort of thing. So there is a memory problem, but it's mild. Mild cognitive impairment can be caused by many different things. In fact, it's caused by the same sorts of things that can cause full-blown dementia. But mild cognitive impairment can also progress to dementia with time. And in fact, maybe about 10% of patients with mild cognitive impairment will progress to a form of dementia, most usually Alzheimer's disease, per year. Some patients with mild cognitive impairment, however, will stay at mild cognitive impairment permanently, and some may even return back to normal, depending on what is the cause of the mild cognitive impairment. So again, it's important to figure out what's the underlying cause if you're told you have mild cognitive impairment. As far as Aricept for mild cognitive impairment, that has been looked at in a clinical trial, and it did not slow the progression to Alzheimer's disease over the time course of the trial, which was 2 years, but it did at 12 months slow the progression. So it's kind of interesting and difficult to think about, but a lot of physicians are recommending using Aricept in mild cognitive impairment because it keeps you better longer, but ultimately you'll end up in the same place. And so it's something that needs to be discussed with you and your physician, but I find that most patients and most physicians do recommend using the medication.
Kim, you're an expert on therapies for Alzheimer's disease and their evaluation in preclinical models. And all of the drugs that are on the market today are what we call symptomatic treatments. Can you explain to the audience what the difference is between symptomatic and disease-modifying therapies?
Sure. So for this, we have to understand what happens in your brain when you develop Alzheimer's disease. And what happens is, as you age in certain people, proteins begin to accumulate. And they accumulate into these structures we call plaques. You've probably all heard the term plaques and tangles. So these are aggregates of specific proteins that for some reason appear in the brains of certain people as they age. And these structures go on to cause the death of nerve cells, neuron cells in the local proximity. And this, of course, is where your memories are stored. This is what gives rise to your personality and everything else. So in these individuals, as they age, they get these protein aggregates which then kill the surrounding cells and cause the dementia that's associated with the disease. So there are two types of drugs. The ones on the market at the moment are symptomatic. What they do is they mask the symptoms of the disease. So they improve the overall cognition for a short period of time. But they don't do anything to stop the death of your neurons, and they don't do anything to stop the accumulation of these plaques and tangles. All they're doing is making you function at a higher level for a short period of time. On the other hand, what our goal is to be able to get rid of these protein aggregates directly, or to prevent them from killing off the surrounding brain tissue. And the idea is that we would call this a disease-modifying trial. And we don't have any of these on the market at the moment, but this is the goal of preclinical research at the moment. And there are a number of promising avenues which are being explored. One of the most promising that actually shows some promise in the clinic is something known as immunotherapy. And this is where you can immunize a patient, much the same way that you would against measles or something else, against the production of these protein aggregates. And so far, this has been shown to have some benefit in a subset of Alzheimer's disease patients. And it's my hope that as better biomarkers for the disease are developed over the next 5 to 10 years, we'll be able to start to immunize people earlier and earlier. And one day, hopefully, prevent these protein aggregates from forming, which will prevent the brain tissue from dying, and people will no longer develop Alzheimer's disease. So we're still many years away from this actually being a reality in the clinic, but this is our goal, and this is what we hope will happen. In addition to this immunotherapy, we have a number of small molecules which are being produced in scientific labs around the world, which also will hopefully one day prevent these proteins from being produced and will prevent our brain cells from dying. So that's where we are at the moment.
You have a question?
I have a question. I'm not sure how many of you have done a lot of work in the psychological or the whole area of the mind in that sense, rather than physically how the mind is working, but more personalities in that. And I found, I was talking to one of the gentlemen before, and the women, very nice people, and I was saying, you know, I have this odd idea. When I never had a whatchamacallit, photographic memory, but I was good. I mean, I could play Jeopardy, and I'm going to come in second anyway, not last or whatever. But I found that when I was in my teens or 20s, if you asked me what's the horsepower and the cubic displacement on an Oldsmobile, I'm going to tell you, and the top speed, and the, you know, how long it takes to stop. And if you then said, what about a Super 88? What about the 98? And so on and so forth. How fast is this? You know, when I was an aeronautical engineer, what's the top speed of this F so-and-so and all? And I found I was never crowded with memories and those things because I loved them. I wanted to know those things. Nobody bothered me, nobody poked me to know those things. Now, I have, I don't know, dozens of passwords, PayPal things, and amazing numbers of things, how to get on. I'm going to pay my taxes soon, and the property taxes, property taxes are coming up in a few days. And you can do it online. It'll save you a lot of hassle or whatever. But again, it has 3 different things to get on. There's 3 different names of passwords. And I'm just wondering, does part of this happen in life where we resent? If I kept giving you work, and they have done studies about this, I mean, I love psychology. They have done studies where you overload, you don't tell the people, the subjects, but you overload them, and eventually they'll kind of break down. You know, there's been executive mice and executive monkeys and things like that. And I'm wondering if part of us just resent memorizing all those things. As opposed to ask me about great movies, because I also write reviews. I love that. I mean, you don't have to bother me, but now I just wonder if we're overwhelmed with a lot of things and if there's any possibility to deal with that in a psychological therapeutic way.
Yeah, and I think the short answer is we really don't know the answer to all your questions, but that we do know that there are some individuals who have superior autobiographical memories, and some of them are being studied at UC Irvine. There was actually a 60-minute piece that was aired not too long ago that featured some of the researchers at UC Irvine discussing this, in particular James McGaugh. And I don't know how many of you remember the TV program Taxi, but Mary Lou Henner is an example of someone who has a superior autobiographical memory. And this is not a photographic memory, it's an autobiographical memory. So she will remember things if she participated in them. And so you can go to her or some of these other individuals and say to them, you know, what was the weather like on February 10th, 2001? Or 1962, and they'll remember, oh, I remember exactly what it was like, and they'll tell you that their information in their brain feels like it's on Rolodex cards, and they just go back through every February 22nd in their brain or whatever the date is, and they'll scroll back through the year. So we're just now starting to identify more and more of these individuals. As you can imagine, they're very useful for doing a lot of imaging studies to try to identify what regions of the brain seem to be larger or smaller than individuals who don't have this particular talent. But I think if you like things, you're more, and learning becomes fun, you're more likely to take to that.
So far, there's been no correlation between the liking and then something you'd see on an X-ray or an MRI? Or
Not to my knowledge, no. I don't think that's, but we do know that the better educated you are, the lower your chances are of developing Alzheimer's disease. And we take education to be a surrogate for intelligence. All right, because we could easily measure education levels. It's much harder to measure intelligence.
And the other thing, not totally related, but I had asked a few people too, I find is how much of an issue is sleep deprivation. Because I'm a night owl, and I'll do all my best creative work at night, and then get up in the morning and forget my orange juice
that's
or whatever.
huge. Amy,
But I don't want to give it up because I'm saying if left alone.
Well, if you sleep okay, it doesn't matter when you sleep. I think you just need to get a lot of...
I don't.
Okay, I think that could be a problem. Amy, you want to answer the sleep deprivation for Alzheimer's? memory?
Yeah, well, sleep deprivation will definitely impact memory as well as other cognitive functions like concentration and attention. Keep in mind, sleep deprivation is not necessarily just someone who's keeping themselves up as a night owl. There's a lot of other medical factors that can impact your sleep, in particularly sleep apnea is a very common cause of sleep deprivation as your breathing becomes disordered and you wake up frequently throughout the night. Sometimes pain makes people sleep deprived. And so assessing sleep is definitely part of our assessment of a patient who is having a memory problem. And that can be part of the treatment, addressing the sleep problem.
So someone wrote an interesting question here, and perhaps you and Malcolm can answer this. And the first part is, does a 12-year-old stroke affect a patient's cognitive abilities? And then a related question that someone else wrote was to define what you mean by vascular dementia. So maybe, Amy, you could take the first part. Will a 12-year-old stroke affect someone's cognitive abilities?
That depends completely on where in the brain the stroke occurred. So the brain, all the functions of the brain are somewhat localized in different areas of the brain. And yes, it is quite true that depending on where the stroke occurred, perhaps if it's in one of the memory areas, then yes, it can leave you with lasting memory problems. And so that's why the neurologic exam is important and why often the MRI or brain imaging is important to help elucidate whether the stroke is impacting memory.
Malcolm, you want to address the vascular dementia, what that is?
Well, actually, Amy would be better to address that. I'll just piggyback a couple of additional points about the effect of stroke and brain damage, and that a lot also depends on the age of the individual at the time that the injury occurred to the brain, and that as we get older, our brain has less plasticity or its ability to correct these problems. But I agree with Dr. Pierce that it's related to where in the brain the stroke occurred, how much damage the stroke produced, and how long ago, because after a stroke there could be some recovery of function, and these other issues would play into whether there's complete recovery or there's lasting effects. And I think Dr. Pierce would be the better person to answer the vascular dementia and the types.
Okay, so vascular dementia is dementia which is due to past strokes or infarcts in the brain, or ongoing ischemia or low blood supply to the brain. And it often presents a little bit differently than Alzheimer's disease. It may not have so much memory deficits early in the course. It may have other problems, it often presents in a more abrupt fashion or and not so gradual. It so happens that the medications that are the cholinesterase inhibitors have also been shown to be helpful in vascular dementia. But the most important thing in vascular dementia is to control the vascular risk factors, like the blood pressure, the diabetes, the lipids, and as well to be on an antiplatelet agent to reduce the progression of vascular dementia.
Great. So we're getting at the closing time. We'll take one more question. Okay, sir.
I'm getting kind of confused. I was told that dementia with Lewy bodies is basically Parkinson's and Alzheimer's with hallucinations. And that Lewy bodies are done by a guy in 1992 by the name of Lewy that determined a protein in the brain. But now I'm understanding that it sounds like all these things are all proteins in the brain and are, although interrelated, are they different? And would one treat a dementia with Lewy bodies if they had that diagnosis the same as one would treat somebody with Alzheimer's or somebody with Parkinson's?
So let me start that, and then the other panelists can chime in. All of the neurodegenerative diseases, Alzheimer's disease, Parkinson's, Lou Gehrig's disease, Huntington's disease, Lewy body disease, all of them are what we refer to generally as proteinopathies, meaning that these are disorders in which proteins start to aggregate and clog the cells or different areas of the brain. Mad cow is another good example of a proteinopathy. What distinguishes them is the type of protein that accumulates and the region of the brain in which those proteins accumulate and in which the cells die. And as you can imagine, if the cells die in areas of the brain that are responsible for motor activity, then you develop symptoms like Parkinson's disease. If they're involved in areas of the brain for memory, you develop more Alzheimer's type symptoms. But it's actually rare to find someone who has pure Alzheimer's disease. There are only about 30% of the cases that we think are Alzheimer's are what we would call pure Alzheimer's, only plaques and tangles. Many of the other cases have mixed pathology. And so you'll see a component of vascular pathology and also Lewy body pathology mixed in there as well. The problem is that they can, when you have a mixture, they can synergize and generally accelerate the disease course faster than if you just have the more pure form of the disease. Malcolm, you want to add anything?
Well, I think we've talked a little bit about Lewy body a number of times during this presentation, and Lewy body dementia is a relatively new diagnosis, probably 20 years ago. It really wasn't talked about, and you did mention a number of the features. It has some symptoms that look like Parkinson's, it has visual hallucinations, and you see marked fluctuations in the person's mental abilities during the course of hours or days. So they can be relatively intact, and then they can be quite confused and come back and be relatively intact, and then back to confusion. So those are the sort of the core features of Lewy body. But many patients, when you look at the brains of individuals who have been clinically diagnosed with Lewy body dementia, and you look at their brain at autopsy, probably about half of them show all of the pathology that you see in Alzheimer's disease as well as these Lewy bodies. So in a living individual, we can say this is suspicious for Lewy body dementia, and at autopsy they may end up having Alzheimer's and Lewy body, or maybe, as Frank was just saying, they could have Lewy body plus evidence of vascular disease.
And one other question. In the research that's going on, you've talked about trying to immunize people so they won't get this disease. Is there any hope for somebody that has it?
Those kind of therapies are still making their way through clinical trials, and they're still in the evaluative phase.
But they are in work.
They're being studied very vigorously by numerous companies throughout the world. Right.
Thank you very much.
Let me just thank everyone here for their attendance and for the questions that you asked. We really appreciate and really love the opportunity to come and serve and help educate the community. There are 3 outstanding booths at the back, the Alzheimer's Association, Alzheimer's Family Services, and the UCI Mind Institute. All have very dedicated staff back there that are ready to answer any of your questions. So please go to them and take advantage of the services and the opportunity that you have. And let me just turn the microphone over to Liz before closing remarks.
Would like to call out again your postcard. Please, please fill it out and leave it with staff at the back. Again, thank you to Senator Harman and Assemblymember Silva for providing us with this opportunity to come and reach out to you. If there are other programs, other interests that you have, we are your research university. We are your University of California, and we love coming and being a part of the community and bringing the campus and all the things that we do there to you. So please, let Senator Silva, or Senator Harman and Assemblymember Silva know that you would like to have us come again in some fashion. And with that, thank you very much. And again, please talk to our staff in the back. They want to be there for you. They are there for you. Thanks.